welcome back to the channel. Recently, a number of hospitals around this country have re-implemented a mask mandate. This is for either healthcare personnel, for staff, or for everybody who walks in that hospital, including visitors. And now they're citing more than COVID-19. They've got RSV, they got influenza, they got COVID-19, they got all the seasonal respiratory viruses, and they're saying because of that, we have to re-implement the mask mandate. This happened in the New York City public hospitals. This also happened in some of the Harvard hospitals. They've re-implemented this. And I think a number of you are probably working at hospitals where you're facing these mandates. It also happened recently in WashU St. Louis while it was out there giving grand rounds. Check out those videos. They're right here on the channel. What do I think about this? I think that this is a blatantly anti-scientific act. It's not comporting with the best principles of science. I'm going to walk you through why that's the case. And I'm going to walk you through, more importantly, I think some of the ways in which providers who work at these hospitals, doctors who work there, professors who work there, can push back on the decision-making process. The first thing to say is, who makes these decisions? We all know, anybody who works in a large healthcare system, that these decisions are made by a tiny handful of incompetent bureaucrats. All these decisions, not just masking decisions, most of the major policy decisions made at a hospital are made by incompetent bureaucrats. They're incompetent because they often get policy wrong. They're bureaucrats because they don't really see patients. If they do, they see them in a token way, maybe one half day a week. So much health policy is set by people who don't have skin in the game. They don't actually participate in the healthcare system. They're not actually there on the front lines. They really don't know what they're talking about. That would be okay, I think, if they understood principles of scientific medicine, but they often don't. Most of their policy recommendations are implemented on the basis of very low credibility science, including quasi-experimental before and after studies, retrospective observational studies, or uncontrolled studies that they have just deployed an intervention. And the entire field of quality and safety is often one of the lowest levels of medical evidence. They very rarely run what they ought to run, cluster randomized control trials. We're going to talk about that. Let's talk about this mask mandate. I think it was abundantly clear a few things. One, masking has been highly politicized. There are people who still love to do it, and there are people who don't like to do it. And the people who love to do it often are young, healthy, left-wing people. It often does not have to do with how sick somebody is, how vulnerable they are to COVID-19. It has to do with a certain type of ideology, and it's taken root on that side of the political spectrum. Now, the next thing is that the evidence to support community masking has always been weak. We have a number of Cochrane reviews, which are systematic reviews of the best available evidence and meta-analyses that show that community mask recommendations, if you look at all the randomized trials ever run, generally find no effect on a reduction in respiratory viral rates. That's historically. That's why when the pandemic started, these masks were not routinely recommended. Then we dug the hole even deeper. People recommended cloth masking year after year. Now we have pretty good randomized control trial data that doesn't work. I think Bangladesh has a number of flaws, but cloth masking failed to work even with those flaws that, if anything, biased it towards finding a signal. So I think cloth masks clearly don't do anything. That was the majority. That's what we did most of the time. Do we have any evidence, credible, randomized evidence, that the current policy of wearing a flimsy surgical mask, asking everyone who comes into the hospital to do that, actually lowers the rate of respiratory infections? I think it's important to think about two groups of people and how you might study this. So I think one thing to think about is, by having this policy, do you lower the spread of somebody who came into the hospital without a respiratory virus acquiring a respiratory virus while they're in the hospital? This is the so-called iatrogenic spread. By making everybody wear a mask, do we prevent iatrogenic spread? The second question, I think, is also salient, which is, by making everybody wear a mask, these group of people who float through the hospital, if you follow them up at 14 days or 21 days, do they have fewer cumulative respiratory tract infections? Because that one brief moment of time when they're in the hospital, you made a mask up, but then they go out and they go to the movie theater and they go to the grocery store and they go to all these places. Is it a wash, or does there actually some persistent benefit at the end of a 2-week period of time or a 3-week period of time? You pick the time. For both of these two endpoints, we have no credible evidence that's the case. We have no credible evidence that making everybody who walks in a hospital wear a mask, even when they're at the coffee shop in the lobby or at the gift shop, lowers the rate of iatrogenic infections. There just simply is no credible evidence to support that claim. The second claim, that it actually lowers the rate of infections over a 15-day time horizon or something like that, not only lacks credible evidence, but it's also preposterous. If you use your brain, you'll realize that they will quickly be overwhelmed with all of the other places we go in our day-to-day lives where we can acquire respiratory tract infections. So I think on both of these two endpoints, we have very poor quality evidence. I also think that there's nothing that stops us from generating the right evidence. So this is what Aid Adamson, who is a really clever health services researcher in Texas, says, quote, mask mandates resume at all 11 New York City health hospitals amidst a rise in flu, COVID, and RSV. At some point, we need a randomized control trial. They probably could have done a cluster randomized trial in New York City. We need higher quality data for this intervention. And Aid is 100% correct that if you want to claim that you're practicing evidence-based public health, you have to generate evidence when you don't have that evidence. You have a gut feeling that this policy might help, but you have no evidence that it actually does help. And you can easily randomize hospitals or wards or floors to have the policy or not have the policy, and you can easily measure the first endpoint. You can also measure, with a little bit of effort, the second endpoint. In response to this, there is somebody who comments, and I think I want to read you the comments and talk about how they're just clearly erroneous and wrong. RCTs cost a lot to run for such a low-cost, low-risk intervention. Spent some time in Department of Public Health, and now I understand the calculations behind what gets randomized and what doesn't. Well, this is wrong in many respects. Number one, Lars Hemkins and others have shown that pragmatic randomized control trials can be run at a very low cost. You can check Hemkins' paper on that. I think it's the Journal of Clinical Epidemiology. That's one. Two, this is not a low-cost intervention. That's a fallacy. One, hospitals have shelled out a lot of money for these useless spun woven surgical masks. Number two, they contribute to environmental pollution. They're strewn about. They're ending up in the oceans, okay? So that's another cost of this. Low risk, there is a downside or risk or harm to having it, which is you deprive people of in-person human-to-human interactions. What does that do for physician burnout? What does that do for the quality of care? What about the patient that's hard of hearing and needs to look at your lips? Another harm is you perpetuate the idea that annual respiratory viral seasons are something that we must be afraid of, that we have to constantly live in this panic, which fuels a whole bunch of other problems. So this person is factually incorrect that it's low risk, low cost, and factually incorrect that the cost of the randomized trial is that much. It won't cost that much. In fact, it can be done very cheaply. It can be done pragmatically. All you need is a little bit of research budget to track these endpoints. The iatrogenic endpoint is a very easy endpoint to track, by the way. You can do that with the EPIC system. The other endpoint will take some phoning up of people. It will take some sort of surveillance or contact surveillance. It'll take some sort of collection of the endpoint. That's not so hard to do. You can hire some low-skilled people, low-cost people to do that endpoint collection. Aid Adamson, I think, replies pretty well. Sure, RCTs cost a lot of money. I think he's even conceding the point that he shouldn't concede. That refers to typically pharmaceutical randomized controlled trials, which typically cost, $30,000 per participant, not these kinds of randomized studies. But they're also one of the best ways to get an answer. Masking has been one of the most political issues of the past 4 years, and RCT would at least bring more clarity. Again, Aid is spot on. People feel very strongly about this intervention. And when people feel strongly and it's making people angry, there's an additional burden upon public health to generate the credible evidence. So I think Aid is making a very salient point. When we talk about what kind of studies should be run, we think about a schema called value of information. What is the value of this information? This information has tremendous value because this is an issue that's very divisive. It also has tremendous value because these people promoting this policy are going to do it year over year over year. This person responds, yeah, it would be nice, but unfortunately health department budgets have also been cut since 2020, so I don't see them doing an RCT for this. Well, that's fine. One, they should be cut because they pretty much bungled everything about COVID-19 response, so I have no sympathy for the health departments that took basketball rims off hoops and chained up playgrounds and closed beaches and poured sand in places where people skate outdoors. No sympathy for the people who work at these departments who made such terrible decisions without consulting the data and closed public schools, by the way, even though the virus had very low risk to children. They bungled that, so their budget should be cut. But you don't need to use the health department budget to run the randomized trial. Whoever said that? We have NIAID, we have NIH, we have many, many groups that have research budgets that could conduct such a randomized control trial. Pretty much the hospitals that are associated with the New York healthcare system include some of the most lucrative hospitals in America. They have tremendous budget and they can run this study, and this study can be run on a shoestring budget. Proof of that is the Bangladesh cluster randomized control trial of masking, which randomized at least 200,000 participants. That was run on a shoestring budget. All right. Aid Adamson. NIH spends billions of dollars on science. Correct answer. Some of that is not even directly applicable to the most urgent problems. Surely the U.S. could muster enough money for a trial. And Aid Adamson says, sure, masks work perfectly, worn under ideal conditions, stop particles, but that isn't real life. This is a policy intervention. We have flu season every damn year, and we can't muster gumption to see if this low-cost intervention actually works. He's so right. If you wear a perfectly fitting respirator or you wear a scuba suit, you're probably not going to get COVID-19 if you do that perfectly. But the problem is when you implement these policies, you know nobody's doing it perfectly. Walk around the hospital. Nobody's even doing it. There is an exemption to wearing the mask mandate. It's called holding a cup of coffee in your hand. You got a cup of coffee in your hand, there's no mask mandate for you. So this is the kind of level of policy that's being implemented by people who would rather signal virtue than actually generate science. I suspect they're probably doing this because they've surveyed their demographic audience and they find that some people coming to their hospital will feel a little more comfortable if this mandate were in place. And I suspect if you look at the places that are doing it and not doing it, it will have nothing to do with cases or hospitalizations and have everything to do with local political valence. Why do I suspect that? Because previously, Sarah Miller and I, in a preprint that's available online, we examined. That was my alarm ruining my video. There's always something. We examined in the preprint. I'm not going to take it out. You know what? I like a one-cut video, and I'm going to keep it in. We examined what led hospitals to drop mask mandates in the first quarter of 2023, and we found it had nothing to do with cases, nothing to do with hospitalization, everything to do with local political valence. You can go and find that preprint. So this very likely is a non-scientific policy being implemented year over year. Ironically, the people who are following this policy doggedly include some of the smartest people who went to medical school. Unfortunately, we don't select for or train doctors to be critical thinkers. We train them to be, if anything, docile, obedient. Those are the characteristics that are selected for in medical training. So as such, you get people who are happy to toe the party line and say, oh, it's too expensive. We can never do it. We have to dig a hole in the sand and put our heads in like an ostrich and be ignorant, rather than people who push back and say, that this is something we can do. Thankfully, we have Aid Adams and we have many other people who are actually pretty sharp on that. I want to show one more picture. One more picture is at one hospital system, they have this color-coded chart. It says masking standards for patients and visitors, low, medium, high, masks not required, masks recommended, and masks required based on the local prevalence. This is a lot like the UV index. When should you put your sunscreen on? It's a lot like that. It's like the risk of forest fire in the park. Okay, if you are working at a hospital system, ask the person who sets this policy the following questions. One, if they're basing it on some threshold, what is the threshold you're basing it on? What is the evidence that masks work above that threshold, but masking doesn't work below that threshold? What will the threshold be when you withdraw the intervention? What is the evidence masks stop working when you go below that threshold? They're going to say the hospital's filling up with patients. Is the hospital filling up with patients whose hospitalization is due to respiratory infection? Or is it filling up with people who happen to have concomitant, incidental, they're there not from COVID-19, but with COVID-19? Which is it? And likely they'll be unable to answer those questions because there's no credible evidence. So this to me represents the worst of medicine. Medicine as ignorant as it was when we were bloodletting George Washington. People doggedly doing something over and over. You could say that about George Washington. Let's take that. Bloodletting George Washington led to his death. He died of pneumonia. You could say that, bloodletting is such a low-cost intervention. We couldn't possibly study bloodletting. It costs so much to study bloodletting, and it doesn't cost any money, and it's low risk. We barely took any blood off. Usually we don't kill them by taking too much blood off. You could say all these things. You could say a lot of people believe bloodletting should work. After all, it drains the body of the bad humors, and after all, a mask blocks the particles. It's just the same sort of low-credibility mechanistic explanation. And in fact, the reality is life is much more complex than blocking particles, and it certainly has nothing to do with draining humors. We learned that a lot later. Bloodletting, ironically, actually does work for two conditions, polycythemia vera and hemochromatosis. So you win some, you lose some. Like a broken watch was right, twice a day. Just was wrong all the other times. All right. So what do I really think is going on here? I think that these fall annual COVID-19 or respiratory virus masking rules are a relic of the broken, dysfunctional cognition that went into the COVID-19 pandemic. This was propelled by many people who are in medicine who just simply don't know enough. They don't know what it costs to run cluster randomized trials of non-pharmacological interventions. They don't know value of information theory. They don't know what the stakes are to run a randomized controlled trial. They don't want a credible answer. And I think that's a problem. We have enriched medicine with too many voices who are ignorant to some of the basic truths in history of medicine. So that's why we end up in this muck. The last thing I'd say, and this is an unrelated point. Recently, Seth MacFarlane was on Bill Maher's show. And I hope somebody writes in the comments that there's a tag for the Seth MacFarlane thing. I listened to Seth MacFarlane and Bill Maher, and Seth MacFarlane denied the value of natural immunity. Bill Maher said we didn't need to mandate a COVID-19 vaccine in somebody who already had and recovered from COVID-19. And Seth MacFarlane said, well, I know people have had COVID 4 times, so just because you've had it doesn't mean you can't get it again, so there is no natural immunity. Wrong, Seth. When people talk about natural immunity from COVID-19, they mean that by having and recovering from COVID-19, your risk of getting it again and getting very sick from getting it again is very, very low. Let's back up. COVID-19 was a concerning virus not because some people had cold-like symptoms, but because a few people got very ill and died. That's why it was a big deal. There are many people who got COVID-19 and actually were asymptomatic. There are many people who just had mild symptoms. That's not why we cared about. We cared about the fraction of people who got sick and died. If you've had COVID-19 and recovered from COVID-19 and you get it again a second, third, or fourth time, your chance of being in that bad group of people who get very sick and die is absolutely floored. We knew it was absolutely floored. There's very, very low risk of you getting sick and dying on the second or third or fourth or fifth or 20th time you get COVID-19. And therefore, it is much more like the cold at that stage than it is the first time you get it for some people. So when people talk about natural immunity, they talk about you have immunity against the thing that you're worried about, which is dying from the virus. When you give the vaccine to somebody, did you know that no amount of vaccines, 5 doses, 6 doses, 7 doses, 8 doses, can stop you from getting COVID-19? Another call disrupting my video. Okay, no amount of vaccines can stop you from getting COVID. I'm going to leave that in too. This is life. No amount of vaccines can stop you from getting COVID-19. But nobody says that's a failure of vaccine immunity because the goal of the vaccine was not to, well, it ought to have been to stop you from transmission, but it was incapable of that for lots of biological reasons. But at least it lowered the risk of severe disease and hospitalization. Now, for somebody who hadn't recovered from COVID-19, is there an additional reduction in severe disease or hospitalization from getting the vaccine? And the answer to that is there's no evidence to suggest that's the case. We could have made Pfizer run studies in those populations to generate that evidence, but we did not. And by we, I mean mostly the Biden administration and the people who work in that administration, hand in glove with Pfizer in a very close partnership, approving annual booster after booster with no credibility data and giving it to 7-month-old babies. It's a very problematic arrangement where government officials are working closely with the company and they're all neglecting the principles of evidence-based medicine and public health. I'm very concerned by that. And I think people like Ashish Jha, Peter Marks, Bob Califf are particularly culpable by setting the evidence bar so low. So Seth MacFarlane, completely wrong, ignorant, and also, to me, it's emblematic of how so easily you can be susceptible to the liberal political groupthink of the tribe that you're surrounding yourself with. Yeah, so Bill was right. You don't need to mandate a vaccine in somebody who hadn't recovered from COVID-19. You're spending a lot of political capital. You're eroding trust in vaccination, and you're actually leading to the catastrophes we see now, which is trust in routine childhood immunization is rock bottomed. Terrible, Seth MacFarlane quote. All right, well, those are my thoughts on this topic. I'm back here, San Francisco. I think if you like this video, you know what to do. Like, subscribe, comment, leave a message below. Hope to put out some more videos in this year. I am also available on the following platforms. On Twitter, of course, Vinay Prasad, MD, MPH. On Substack, you got to check out my Substack. I'll put the link below. And now on Instagram. On Instagram, I'll try to put some short clips of my videos and follow me there as well. Vinay Prasad, MD, MPH. And I'll be back. If you have any suggestions about what we should talk about, what we should cover, leave it in the comments below. Hope to cover some more papers in the future. I've got some really good stuff that we're about to publish. And once I publish the paper, I'm going to cover it on this channel. So until next time.